and Happy New Year, and also to welcome you and to thank you for the consistent support and networking. We didn't know when we were finishing in December where we would be with COVID or what the numbers would be like, and very sadly they have gotten worse, and we've seen all those spikes happen, and we know that everybody's been incredibly busy. At the same time, we know that we have patients who have other issues, and we still need to connect and network. So we were a little bit worried about starting the year not talking about COVID, if I'm honest, because we thought, well, gosh, people will think it's a bit mad we're not talking about COVID. And we almost had a Father Ted exchange going, we can't not talk about COVID. But at the same time, things are moving fast. We will have information next week's webinar. We will be doing another one next week about COVID. And actually, we all still have patients who have issues that are perhaps even going undetected, particularly in the area of cancer care, because we are all so preoccupied and testing hasn't been carried out in the way that it should. So I actually think this evening's topic is a wonderful one for us to be starting with, particularly any other year at the start of the year. We would have been looking at things like lung cancer, smoking cessation. So fantastic that we're doing it tonight. And I'm really, really grateful for our colleagues from the National Cancer Care Programme to be joining us here this evening. So I'm going to hand over to Sarah, who's hosting you this evening. But what I did want to just say is thank you for your ongoing support. You're constantly telling us what you like about these and what you'd like to see more of. It gives us a great sense of connection with the profession to see you here. There was over 400 registrants. There's 250 of you on at the moment. So thank you. I have missed them because I'm doing a course in the evenings that is every Tuesday and Wednesday night. And I haven't been able to make them. So I'm really sad not to have been able to do that. But I listen to the recordings every week, and some of our recordings, 700 or 800 people have been listening to them. So it's been a popular initiative from the Institute. So it's lovely to see you, and we will see you again shortly. But I'm going to hand over to Sarah, and we have some very good speakers this evening. So I'll ask her to introduce them. Thanks, Sarah.
Thank you very much, Katrina, and it's so lovely to see you all this evening. Happy New Year to you all. I'm going to share my screen now, so hopefully you can see that. It is so lovely to see you all. So tonight's webinar, as Katrina mentioned, we have presenters from the National Cancer Control Programme here to talk to us about the important role that pharmacists play in the early detection of lung cancer. So a really important topic, and we have an awful lot to cover. So I'm going to quickly run through a couple of domestics before we get started. I know you're probably all very familiar with these by now. So first things first, our mics need to be muted. It's always really nice to see people with your videos on, but if you are having any problems at all with your internet connection, sometimes turning off your video can help. If you're having any difficulty with sound, try logging off and logging back in again. That usually does the trick. Our NCCP colleagues will be keeping an eye on the chat box this evening, so we'd really encourage you to use it. It's always really nice to see your comments and questions coming through there. The webinar is being recorded, as Katrina mentioned, and that's for people who can't make it this evening, or indeed for yourselves if you'd like to go back over it at any stage. As always, we will do our best to be finished by 9 o'clock. But for now, let's get started. So I'm really delighted to introduce tonight's panel. We have 3 fantastic presenters here for you tonight. We have with us Dr. Heather Burns, consultant in public health medicine in the National Cancer Control Programme. And over the course of the pandemic, she's worked across a number of national roles in the HBSC and the Department of Health, but she's returned now to her important role in the NCCP, focusing on the prevention and early detection of cancer. Our second presenter of the evening is Patricia Heckmann, Assistant National Director and Chief Pharmacist in the NCCP. His role has a strong focus on patient safety and best practice in the areas of tumour guideline development, community oncology, and cancer intelligence. And last but not least, we have Dr. Una Kennedy. Una is a GP in Dublin and is GP advisor to the National Cancer Control Programme. So without further ado, I'll hand over to our presenters tonight. So I'm going to stop sharing my screen now, and I'll hand the mic over to you, Heather.
Thank you. So is that sharing okay?
That looks perfect, Heather, yep.
Great, brilliant. So good evening, everybody. My name is Dr. Heather Burns. I'm a public health doctor working in the National Cancer Control Programme. I'm delighted to be here with you this evening. First of all, I'd just like to say a very sincere thank you to all of you for joining us this evening, and to IOP for hosting this webinar and for facilitating us to talk to you about the importance of the pharmacist in the early detection of lung cancer. So the way this will work is I'm just going to give a very brief introduction and overview of what we do in the National Cancer Control Programme, and then I will hand over to my colleague Patricia Heckmann, and she will expand on the role of the pharmacist within the National Cancer Control Programme. And then Patricia will hand over to Dr. Una Kennedy. She's our GP advisor, and she'll take you through the main body of the presentation, and this will include the epidemiology of lung cancer in Ireland and the role of the pharmacist in the early detection of lung cancer. So just to start with then, the National Cancer Control Programme is a directorate within the HSE which manages, organises and delivers cancer control on a whole of population basis. The NCCP was established in 2007 to implement the National Cancer Strategy 2006 with the aim of reducing cancer incidence, reducing cancer morbidity and mortality, and improving the quality of life for people living with cancer. So the role and function of the NCCP has evolved over time to reflect changes related to the ongoing restructuring of the health services. But the role predominantly focuses on delivering on cancer policy, including service planning, quality assurance, and performance management of publicly delivered cancer services nationally. So as you may be aware, our current national policy document for cancer control is the National Cancer Strategy 2017 to 2026. This policy document contains a suite of 52 recommendations, and these are to be delivered by cancer stakeholders, including the Department of Health, ourselves in the National Cancer Control Programme, other stakeholders across the HSE and the voluntary sector. So I work in the Community Oncology Division of the NCCP, and our work primarily focuses on cancer prevention and early detection. And this includes coordination of a national cancer prevention network and development of initiatives such as awareness raising initiatives to improve early detection of cancer. We also support voluntary organisations like the Irish Cancer Society, the Marie Keating Foundation, and Breakthrough Cancer Research in the planning and delivery of their own cancer services, including awareness initiatives. The other divisions in the NCCP work across many other areas, including service planning and monitoring service delivery in the acute hospitals, including chemotherapy, radiotherapy, and cancer surgery, development and publication of national clinical guidelines, rollout of the National Cancer Information System, and development of survivorship programs. So as you can see, the NCCP has a role across the entire cancer continuum, from prevention right through to survivorship. Now, the focus of this evening's webinar is quite upstream in that cancer continuum. So we're focusing on the early detection of lung cancer. Early detection of cancer is a key objective of our current National Cancer Strategy, because by detecting cancer earlier when it is more amenable to treatment, we can of course optimize patient outcomes and reduce cancer morbidity and mortality. So on that note, I'm going to hand over now to my colleague Patricia Heckmann, and she will elaborate on the role of pharmacists within the National Cancer Control Programme.
Thanks for that introduction, Heather. And as Heather mentioned, my name is Patricia Heckmann and I'm the Chief Pharmacist in the NCCP. It's lovely to have the opportunity to speak to so many of you all at once, and like Heather, many thanks for taking the time to attend this talk. I'm taking the opportunity and have promised to be brief to introduce NCCP resources that are there to support you in your practice. The IOP have already shared with us the aggregated registration data, and I'm delighted to see that many of you are already aware of and are using these resources. As Heather said, the NCCP Systemic Therapy Programme is part of the overall NCCP programme, and we're responsible for overseeing national services for the treatment of cancer with systemic anti-cancer therapy. We are currently developing a model of care, which we hope to finalise this year. And then on the next slide, we have our 26 public hospitals, which are in a hub and spoke model. That's perfect, thanks Heather. And there are 9 designated cancer centres, and one of those is a paediatric centre in CHI Crumlin. And then there are 17 other hospitals providing systemic therapy services as well. On the next slide is one of the resources which you may find useful, which are the national chemotherapy regimens. Currently, we have over 340 regimens approved, covering over 570 indications. These are all available on our website, and we have a subsection specifically for oral anti-cancer medicines. These regimens have been developed to support safe, evidence-based and cost-effective cancer treatment, and they are developed under the guidance of medical consultants and other healthcare professionals. They are also the basis of the regimen library of the National Cancer Information System. The next slide just is a slideshot of what the page looks like and a sample of one of those regimens, which is osimertinib. The next slide is about the National Cancer Information System, and the NCCP is facilitating the rollout of this to hospitals providing cancer services. One of the aims of the project is the provision of a patient-centered, longitudinal and accessible care record around systemic therapy to ensure that the right information is available at the right time and in the right place to ensure safe and effective chemotherapy, prescribing, administration and scheduling. We in the NCCP are working with the vendor on the development of a discharge prescription to improve the safety of OAM prescribing and dispensing in line with the NCCP OAM model of care. As Heather said, pharmacists are a huge resource in terms of their role in cancer and the management of cancer patients. And on the next slide, you'll see while we have 43 acute hospitals, we have over or just under 1,900 community pharmacies and 6,700 registered pharmacists. And as Heather said, our profession is well positioned to have a positive impact on prevention, early detection and treatment of patients with cancer, as well as roles in screening, promotion, cancer survivorship and palliative care. And we in the NCCP look forward to further supporting pharmacists in these roles. My last slide, and I promise to be brief, is to signpost the IOP Oral Anti-Cancer Medication online course. This is a self-directed online program with 4 modules. I want to thank Dr. Claire Meany, who actually was very involved in the development of this course and actually pulling all of this program together as well. Thank you for listening. I'm going to hand you over to my colleague, Dr. Una Kennedy, who I hope has managed to overcome her technical difficulties and is on the line. So thank you again.
Una, can you hear us?
Okay. Thank you. I can hear you. Can you hear me?
Oh, lovely. We got you on. Perfect.
Great. It worked in the end. Thank you very much, everyone. And thanks, Patricia, for a really fantastic presentation there. My name's Una Kennedy. I'm a GP and I work for the NCCP as well. And I'm going to talk about the importance of pharmacists in the early detection of lung cancer. Everything we do in the NCCP is about improving cancer outcomes. That is our bottom line. We don't want people to get cancer in the first place, which is the best outcome. But if they do, if we can improve survival and improve healthy survival, that's the sort of outcome that we're looking for. And we really do think that pharmacists have a role to play here. So I'm really delighted there's so many of you here and delighted to get the invite from IOP. I think as healthcare professionals, we probably don't talk to each other enough. And I obviously have a very sad and empty life, so I was really very excited when I heard that I was going to be doing this webinar this evening. So the next slide, please, Heather. Why lung cancer? Why are we so het up about lung cancer? Well, this is the reason in a single sentence. Lung cancer is Ireland's single biggest cancer killer. It is not our commonest cancer, but it is our commonest cancer killer. And I keep clicking buttons there, please, Heather. We see over 2,500 cases per year and 1,800 deaths per year. It's a real cancer burden. Up to 80% of cancers are caused by smoking. So in an ideal world, of course, nobody would smoke. It is the second commonest cancer in women and the third commonest in men. So as I say, it is not our commonest cancer, but it is our commonest cancer killer. It accounts for just over 11% of all cancers in Ireland. And the 5-year survival is very strongly linked to your stage at diagnosis. Now, I'm sure you all know this, but just to recap, when we talk about cancer, we often talk about 5-year survival, which is the percentage of people who survive for 5 years after diagnosis. And increasingly, I'm glad to say, we talk about 10-year survival, the percentage of people who survive 10 years after diagnosis. We also divide cancer into stages. They would be stage 1, which is the most early stage, stage 2, stage 3, and then stage 4, which would be the latest stage. there is also a stage, so-called stage unknown. And that means that somebody has been diagnosed with a malignancy, but they haven't actually been told what stage they're at. Usually this happens because somebody may pass away before they have time to be staged, or they may be deemed to be so unwell or so frail that they're not able to tolerate the investigations that would be needed to be done to stage them, and so they don't get staged. So stage unknown typically means late stage. And if you keep clicking, Heather, you can see that stage 1 survival is 51%. So 51% of people can be expected to survive for 5 years if they're diagnosed at stage 1 lung cancer. For stage 2, it plummets down to 12%, which means that just 12% of people with stage 2 lung cancer can live for 5 years. Excuse me. By the time we get to stage 3, just 9.4% of those people will survive for 5 years. And at stage 4, it's a very mere 4% of people will make it to 5 years. So the difference is absolutely enormous. And there's a huge amount to be gained between stage 1 and stage 4. And that's what we're fighting for, that gap there, to bridge that gap. So the next slide, please, Heather. So that's the problem. Lung cancer is a very common cancer in Ireland. It is our biggest cancer killer. We know that if you're diagnosed late stage, your chance of survival is quite poor. And on top of that, we know that if you are diagnosed with lung cancer, you're more than likely going to be diagnosed at late stage. Unfortunately, just 18% of people with lung cancer are diagnosed at stage 1, and the remainder are diagnosed at stage 2, 3, 4, or unknown. Next slide, please, Heather. This compares lung cancer survival overall to the other more common cancers in Ireland. We often talk in Ireland about the top 5 cancers, and there they are in no particular order: prostate, skin, breast, bowel, and lung. Now, these data are from the National Cancer Registry of Ireland, and they show you 5-year survival for these 5 cancers. Data are quite old, so you can be sure that the numbers are a bit better by now, but just you can compare them quite easily. You can see prostate has an almost 90% 5-year survival, which is great. Skin is over 90% 5-year survival. For breast, it's over 80, and for bowel, it's about 60. And lungs very much bringing up the rear there with a mere 18% 5-year survival overall. So when you put them all into a box, whatever stage of lung cancer, just 18% of people overall will survive for 5 years. So it's not doing well, and it's not doing well compared to the other cancers. The next slide, please, Heather, thanks. And if the present situation with lung cancer looks bad, unfortunately, the future is looking very grim as well. As I say, there are currently about 2,500 cases of lung cancer every year in this country, but the National Cancer Registry of Ireland reckon that by 2045, that will more than double. We'll have over 5,700 cases of lung cancer per year, every year in this country. And when I was doing this slide, I remember thinking, well, 2045 seems like a long way away. But of course, it's not actually a long way away. 2045 is our lifetime, and it's us, and we will be seeing these changes. Next slide, please, Heather. So who's going to get lung cancer? These high numbers that we're expecting coming down the tracks to us, who's it going to be? Well, we know that it's a disease of older people. And this slide here shows you the age profile at diagnosis and at death. So the age of diagnosis tends to be for older people. 97% of cases are in people over the age of 50 years. And if you drill into them a little bit further, you can see that 72%, almost 3/4, are in people over 65. It's a disease of older people. When you move on to who's dying from lung cancer, again, it's a disease of older people. 98% of deaths occur in people over the age of 50 and 75% over 65. And if you look down at the bottom of this slide, you can see the median age group at diagnosis is 70 to 74, and the median age group at death is similarly 70 to 74, which is a figure that I always find very sad, because I look at it and think that this really strongly shows that these unfortunate people just don't live very long. They just don't survive very long. They get lung cancer, and they're not around a whole lot of time after that, unfortunately. The next slide, please, Heather, thanks. And again, who's at risk? Who's going to get lung cancer? Well, we just established smokers. 80 to 90% of lung cancers are caused by smoking, be they current smokers or ex-smokers or passive smokers. Now, you'll find variations in that number. I've seen anything between 75% and 95%, but I think you're dancing on a pin at that stage. Most of them are caused by smoking. We've established that it's a disease of older people. 97% of them occur in people over the age of 50, and the median age of diagnosis is 70 to 74 years. Should be said that it affects men and women. It almost affects men and women equally at the moment. But in the next couple of decades, we know that women will reach and then they will overtake men in terms of lung cancer. And by 2045, this is going to become a predominantly female disease, not a male disease, a female disease. I think it's really important to stress that, because certainly, excuse me, as doctors, we all think of lung cancer as a male disease, a bit like cardiovascular disease. But it's not going to be for a whole lot longer, and we just need to keep an eye out for our female patients, lest they be forgotten. It's not entirely sure why this is happening. They think that it's to do with changing culture. It may well be that female lung is more susceptible to cigarettes, but what they really think is happening is that if you imagine a woman now who's 70, who's at risk of lung cancer, she would have been born in 1950. And way back then, smoking in women simply wasn't considered socially acceptable. So they didn't smoke and they didn't get lung cancer. But then we headed into the 60s and 70s, and women's lib arrived and women could smoke, so they did. And now those women are aging and they're starting to develop lung cancer. They think, anyway. COPD, that's chronic obstructive pulmonary disease. That's really typically known as smoker's lung disease. So that's the lung disease that some, but not all smokers get. And you know these people, they're on a lot of inhalers, they're getting regular steroids, regular antibiotics, they're in for cough bottles. That's associated with an up to 5-fold increased risk of lung cancer. So that if you have if you're a smoker, you're at risk of lung cancer. But if you have COPD as well, your risk is higher again. It tends to be more common in urban dwellers than in rural populations. It's strongly associated with socioeconomic deprivation. And they have found that rates of lung cancer in the most deprived 20% of the population are about 60% higher than the least deprived, the most affluent. And as you might expect, it's associated therefore with low education or leaving school early, and it's associated with low employment, which is poorly paid employment or no employment. And finally, radon gas. Certainly in Ireland, radon deserves a special mention. Radon is an interesting thing. It's a gas that occurs naturally in our environment. It is produced by rocks, by stone, by soil, and also it comes from outer space, from cosmic radiation. And I promise I did not make that up. I thought somebody was winding me up when they told me that once, but that's true. It comes from outer space. And for reasons I can't explain, we seem to have more radon in Ireland than in other parts of Europe. And it's thought to account for about 10%, maybe a bit more, about 10% of our lung cancers, about 300 lung cancers per year. And rates of lung cancer are higher in areas with moderately raised radon levels. It's also an unfortunate thing that the effect radon has on smokers is higher than in non-smokers. So smoking and radon seem to act synergistically. The next slide, please, Heather. So the next here is a map of a radon map of Ireland. And this is from the Environmental Protection Agency. Radon can be either natural or man-made. About 86% of our radon is natural, and the remainder is mostly medical related. So you're talking about things like x-rays and so forth. The radon risk to an active smoker is 25 times that of a non-smoker. So, you know, anybody might be at risk from radon, but if you're a smoker, your risk from radon is 25 times higher than a non-smoker. And if you look at the map here, it's kind of self-explanatory. The red bits are the bits where radon levels are high, and the pale bits are the areas where radon level isn't so high. And anybody who needs or wants to know more about radon can find out more on the EPA website. That's the Environmental Protection Agency website at epa.ie. The next slide, please, Heather. So going down through all those previous slides up to now, we've got a profile of the type of person who's at risk. And as I'm looking at it here, you can see who is at risk. The older person, the smoker, the ex-smoker, the passive smoker, the socioeconomically deprived, and people exposed to radon. So that's your profile of who's at risk of lung cancer. And then if you have an idea of that person, what sort of symptoms might they have that would suggest lung cancer? And the signs and symptoms of early lung cancer can be very subtle and easy to miss. The biggest sign is cough. Cough is a presenting symptom in about 65% of cases of lung cancer, but unfortunately, cough is really common. And it's really common at the moment with COVID. And it's really common in the winter time. So it's not a very useful sign, but it actually is the big sign for lung cancer. So if you think of cough, you think of, say, somebody who's always coughing, like our smoker's lung disease person. But if they come to you and say their cough is changing, or the cough usually goes away, but now it's there all the time. And actually people are very good at spotting what their normal cough is and what's not normal for them. And the smokers who are coughing all the time, they'll tell you, this isn't my usual cough. I know my usual cough. So if they say things like that, it's time to have the antennae up. Appetite reduced or weight loss. And that's weight loss that's unexplained. If somebody just suddenly starts shrinking in front of you for no explanation, you really need to start looking at them. A new onset cough. Cough merits a second mention, but also a new onset cough in somebody who never coughs. So there's the smoker type person who's always coughing and they see the cough changing, but there's also somebody who never ever coughs and suddenly they are coughing. Chest or shoulder pain, and you can imagine a tumor pressing on the chest wall or pressing on an area where pain is radiated up to the shoulder. If they're easily breathless, and again, what you're talking about is the person who says, I could always walk down the road to the shops, but I can't now all of a sudden. Or I could always get up the stairs without any bother, and now I can't make it. That change is very significant and needs to be looked at. Or if they're really tired, and unfortunately this could be, this is a symptom that crops up when you're reading up on lung cancer or almost any other cancer, and it's very, very vague. I mean, everybody's tired, everybody's really tired, and it's really hard to sift out the people who might be tired because there's something going on, or people who are just tired, but it is there, it is one of the symptoms. And if you put those two people together, the at-risk group together with those symptoms, you get a feel for the sort of person who's most at risk. I can tell you, for example, that there are about 600,000 people over the age of 65 in Ireland, and about 9% of those people smoke. So about 61,000 smokers over the age of 65. And in the case of GPs, a bit like a pharmacist, there's 1,800 practices in Ireland, general practices, that we know of anyway, on HealthLink. And that would equate to about 33 people per practice that would fit that description, that are over 65 and are smokers, give or take, allowing for population changes in different areas. But I can tell you, when I found that out, I could almost name those 33 people in our practice, and I would guess that most of the community pharmacists could almost name the people coming into their pharmacy who fit that profile. The next slide, please, Heather, thanks. This is worth a mention too. This is hematosis, which you all know means coughing up blood. And this is probably the most famous sign of lung cancer. It's the one everyone thinks of, and everyone says, I coughed up blood, I get it checked. Well, hematosis is not a common presenting symptom of lung cancer. Obviously, if somebody has hematosis, they have to get it checked, but it's not common at all in lung cancer. It's a presenting symptom in just 5% of cases, which means just 5% of people with lung cancer will come in on day one and say, I started coughing up blood, what should I do about it? So it's not common at all. And overall, it only occurs ever in about 20% of lung cancers. So it is not a common symptom, and it's not something that you can wait for, really. So the next slide, please, Heather. So if you just click away there, Heather, we all know this guy, this elderly gentleman, deprived elderly smoker. He's one we wouldn't miss, you'd think. We all know the younger guy, who may well be over 65, may not be a smoker, maybe fitting well, but maybe a passive smoker. And don't forget the ladies either. They're going to be at increased risk of lung cancer, especially over the coming decades. And if you compare those people up with the symptoms of cough, weight loss, new onset cough, chest or shoulder pain, easily breathless or really tired, you can narrow down the type of people who might be at risk of lung cancer. So why aren't they getting picked up? If they're that easy to spot, why aren't they being picked up early? Well, when we talk about barriers to diagnosis, we talk about patient factors and doctor factors and system factors. And I put this slide up here because I thought what really jumped out at me preparing for this webinar was that there's no pharmacy factors there. And you'd never hear of pharmacists getting in the way of a diagnosis. It just seems to me that pharmacists are actually more likely to be facilitators here and are more likely to be people who can enable their patients to get a diagnosis. These are some of the patient factors we found, and if you just click away there, Heather, you spot all the little yellow arrows popping up. Fear of what the doctor might find is a really common one, and that's really understandable. Everybody's afraid of a cancer diagnosis. I don't matter is one that crops up quite a bit. Don't mind about me, sure, I'm old, who cares whether I get cancer or not. The cost was one that cropped up, the cost to see a GP, unfortunately. Then there was a sense of fatalism, the sense that if you get cancer, there's nothing that anybody can do about it, and you're better off not knowing anyway. The feeling of wasting a doctor's time is particularly pertinent at the moment with COVID, because it seems patients think we want to do nothing but COVID, and we're only interested in COVID, and it's not COVID, you shouldn't be coming to see us, which of course is not true at all. Some people would say that they're too busy, which I think is very similar to fear of what the doctor might find, that they just don't want to come and see us. And then finally, stigma and shame. And this is a really powerful one. Smokers know they shouldn't smoke. They know that they're addicted. They know it gives them lung cancer. It makes them sick. And there's a very strong shame around that. And if or when they do get sick, there's an awful lot of shame about the feeling that they might have brought it upon themselves or they caused it themselves. And there's a shame that they've brought this grief on their families as well. And unfortunately, they feel that stigma and shame coming from their doctors as well. But it shouldn't be like that. If you move on to the next slide, please, Heather. This is a very famous epidemiologist in London. And this is how he describes it. Researchers linked smoking to cancer in the 1950s. Now, remember a few slides back, we were saying that somebody who's 70 years old now would have been born in 1950. So they were born before anybody knew that smoking caused cancer. That's the world they were born into. The world where doctors used to smoke on ward rounds. And I've heard stories of people delivering babies while the obstetrician had a cigarette in his mouth while he's delivering babies. That's the world that they were born into. The link was made in the 1950s. Doctors didn't believe them until the 1960s, by which time your patient is a teenager. She was born in 1960. And there was no internet back then. There certainly were no webinars. So this news just wasn't propagated. And it wasn't until the 1970s that journalists found it, and then the public took notice. By this stage, your person born in 1950 is well into their 20s, and they are well addicted to cigarettes. Next slide, please, Heather. We did some work in the NCCP about barriers to diagnosis, the patient factors, and it was very interesting. And bits were actually more funny than they should have been, I think. If you take away, this is the first line is my favorite as a GP. I would rather die than see a doctor, literally, which is just charming for a GP to hear. The next one is cancer means death. And that cropped up again and again and again. If you have cancer, it's all over. It's too late for you. Nothing can be done. And then finally, this one cropped up a lot. It's too late for me. Why aren't you talking to my children? They're more important. It's too late, meaning I'm too old to be bothered about. I'm an old man. I'm an old woman. My day is gone. Don't bother about me. I'm not important. Take care of my children. They're more important. That cropped up again and again and again. This notion that if you're 70, you're done. If you click on to the next slide, please, Heather. I don't know how it looks to all of you looking at this, but as I see it, the guy on the left just became the most powerful man on earth. And the guy on the right started a riot last week, and they're both well into their 70s. So it is not the case that you turn 70 and it's all over. So next slide, please, Heather. And these were doctor factors. We did some doctor focus groups about the barriers to diagnosis. So why aren't we picking it up and sending these people in for tests? And it's worth noting here, this is from Lancet Oncology 2013. More than a third of patients consult 3 or more times before they're referred. So what were the doctors saying? Well, again, there was this fatalism around lung cancer. somebody diagnosed with lung cancer and he was dead 6 weeks later. And that happens, it does, but it doesn't have to be like that. There was the judgment and the stigma, they're all smokers. And then finally, there was a lack of awareness. Some GPs didn't know what the RALCs were. RALC stands for Rapid Access Lung Clinic. And these are the lung clinics that were set up for rapid diagnosis of lung cancer. And what it means is that if I have somebody that I suspect has lung cancer and I send in a referral on them, they will be seen within 2 weeks. They get a really quick appointment. So this notion that you're left sitting on a waiting list forever, it just doesn't apply in the case of lung cancer. The next slide, please, Heather. Yeah, COVID-19 brought its own unique barrier to lung cancer diagnosis. These dots, each dot represents the number of referrals made by GPs every week to the cancer clinics. So the little orange dots, yellow dots represent pigmented lesions. That's the malignant melanoma clinics. And each yellow dot represents the number of referrals made in a particular week. The green dots represent prostate referrals by GPs. So each green dot is the number of referrals to the prostate centre every week by GPs across Ireland. And finally, the blue dots represent the number of referrals made by GPs per week to the Rapid Access Lung Clinic. And you can see them all ticking along at the usual rate. And then the hatched yellow line, you can see it there on the 12th of March, that's when the schools closed. And the rate of referral just plummeted. And then the hatched purple line are the further measures introduced on the 27th of March, when we were all basically put on lockdown, and that kept them low. But then as time goes by, you can see that they start to rise. So you can see the pigmented lesions, they be the ones for malignant melanoma, they start to rise and they recovered fully, which is great. Prostate starts to rise. It hasn't recovered fully on this slide, but I can tell you that it has recovered fully since, which is great. And then down at the bottom, we see lung. And lung has not recovered. Lung is limping along the bottom there. And we are just not doing as many referrals for possible lung cancer. One of the reasons for that is that we're just not seeing people. And one of the reasons for that is that, as we know, lung cancer affects older people, and people over 70 were told to cocoon. And also, the big symptom for lung cancer is cough. And of course, cough is one of the signs of COVID. So people are afraid they have COVID. Next slide, please, Heather. So where do pharmacists come into all of this in the early detection of lung cancer in Ireland? Next slide, please, Heather. Well, we had a look at some information about pharmacists, first of all. And this is from the Pharmacy Usage and Attitude Survey 2020. And it's very, very interesting. This shows the number of people per age group, the percentage, I should say, of people per age group who attended a pharmacy in the last week. So the x-axis is the age group and the y-axis are the percentage of that age group who visited a pharmacy. And as you can see, when you get up to the over 65, 51% of people over 65 visited a pharmacy in the last week. That's our target group for lung cancer. Half of them visited a pharmacy in the last week, whereas just 17% visited a GP. The next slide, please, Heather. To go on a little further, almost 2.1 million people visited a pharmacy in the last week in Ireland. Now, this is based on the 2019 survey. The monthly attendances increases rapidly with age. Now, of course, you'd expect that because people are getting older, they're on more medication, they get more sick, so they're in and out more often, I would imagine. And then we have some really staggering numbers. 98% of people say they trust the advice and patient care they receive from the pharmacist. 98% of people value the professional advice they receive from the pharmacist. I mean, these are staggering numbers. So huge numbers of people visit the pharmacy, huge number of people trust the pharmacist. It puts the pharmacist in a position of power and influence, I would say. So next question is, what are you going to do with all that power and influence? Well, the next slide, please, Heather. And we're on to how do we overcome barriers? Well, this is what we would suggest. The first thing would be to listen. Simply listen to the patient. They may be trying to tell you something. I suppose remember that they're embarrassed, they feel awkward, they know they shouldn't be smoking, but they might still be worried about that cough that they have. And they may be down to ask you about the cough. And why am I getting all these antibiotics? Sure, they're doing nothing for me. And that last cough bottle I got, that was rubbish. They may be trying to say, I have a cough, I'm worried, can you help me? but they say it without saying it, of course. Understand that they may feel fatalistic about cancer and ashamed or embarrassed, so they may be terrified to say anything. They may think, if I have it, I'm a goner, and may not feel able to say anything. It's worth noting symptoms that are new are not normal for somebody. So if there's somebody who never coughs and they suddenly have a cough, or somebody who suddenly come in looking for painkillers for chest or shoulder pain, and they've had no injury or they've never needed painkillers before. And finally, give them encouragement to attend their GP to seek help for symptoms. It has been purported that some people almost feel like they need permission to get help for symptoms, particularly the smokers. They feel that they don't have any right to seek help and that they shouldn't be annoying people, and if they're sick, it's all their own fault. So they need a nudge from somebody that they trust and somebody that they respect. We think that somebody could very well be yourselves. It's worth saying to them that treatment is available, particularly if you're picked up early stage, and the first step is usually a chest x-ray. Because you'd be amazed how many people, the first thing they'd say to you is, oh, I'm not getting chemo no matter what. You're like, there's nobody offering you chemo. I'm just organising a chest x-ray. Chemo is not the first step. The first step is the chest x-ray. It's really easy. The next slide, please, Heather. This is what we suggested as a patient pathway here. For example, somebody might notice a cough. They come down for a cough medicine. They come down again. They're asking you about the cough. And then you might say, well, you've had a few cough bottles. This is your third course of antibiotics. What's happening with you? A nudge from yourselves to contact their GP may get them to come in to see one of us. Hopefully, we would think to send them for a chest x-ray. If that's not normal, we refer them to the Rapid Access Lung Clinic, where they get an appointment within 2 weeks. They go to the Rapid Access Lung Clinic and they get a diagnosis. And that's the sort of pathway we imagine happening. It's one of the pathways to a diagnosis of lung cancer. The next slide, please, Heather. So to sum up, lung cancer is Ireland's biggest cancer killer, and numbers set to grow rapidly in the coming decades. Pharmacists, we believe, are ideally placed to help in the fight to improve early detection of lung cancer in Ireland. Pharmacists are trusted healthcare professionals, there's no doubt about that, and they have millions of weekly contacts with patients. Like I said, 2.1 million people visited pharmacy last week. There's only about 5 million of us in the country. These are huge numbers. And we just would suggest to be vigilant for people at high risk of lung cancer, the elderly, the smokers, the deprived, the COPD, the frequent cough bottles or antibiotics. And the summary is to listen, understand, note, and give encouragement. The next slide, please, Heather. And these are some resources. They are on the hse.ie/cancer/think-lung site. You can follow us on Twitter at HSE-NCCP or email us at prevention@cancercontrol.ie. So that's it. That's me. That's lung cancer early diagnosis in Ireland. Thank you all very much for coming and for listening. And if there are any questions, I think we'd be delighted to hear them.
I had a couple, Una, come directly into me. I can read them out to you.
Sorry, say that again, please.
I had a couple of questions that came into me. So I had one here. They think it might have been answered in your presentation, but I'll read it out anyway. So we'd want to come in. Can lung cancer be disguised by COPD or asthma initially? So is there a particular deterioration that we should watch out for?
It can, unfortunately, it can, and the symptoms are very, very similar. You're talking about a cough and a chesty cough, and sometimes people with COPD particularly can lose weight, they become quite thin. Sometimes they're not, they actually gain weight due to all the steroids. But I think the key thing about COPD particularly, and indeed asthma and lung cancer, is that generally these people are really, really good at knowing their own cough. And my little one has asthma and she recently had a cough, and I knew it was her asthma cough. Now she had to get checked for COVID, but I knew this was her asthma cough. I know the sound of it. And the COPDers are a bit like that as well. They're very good at knowing their own cough and what it normally sounds like. So yes, it can be disguised. Lung cancer can be disguised by COPD, but if you listen out to the COPDs, they'll come in and tell you, this is not my usual cough. It's different. I know it's different. Or my cough normally goes away with this antibiotic and this steroid. It hasn't gone away this time. There's something funny about this one.
Lovely. Thank you for that, Una. I have a couple more here, if you don't mind.
Go ahead.
Yeah, lovely. So we have one in here. Is there any data linking vaping and lung cancer? So they said they have a lot of patients asking if swapping from cigarettes to vape would reduce their risk. And is there any particular free lung cancer screening services that they should be signposting their patients to?
I suppose for vaping, there is no data yet that I know of connecting vaping to lung cancer. But I think the problem for that is that vaping has not been around for very long. So if you imagine smokers will often start, say, in their 20s, but they may not develop lung cancer until their 70s. It may well be that vaping has a similar pattern, and we just haven't seen it yet. Certainly the people who know a lot more than me about these things would say they want people to avoid vaping because they view it as a gateway, as habit formation, and particularly the number of teenagers starting vaping is quite worrying. So they would strongly say keep away from vaping if you can. In terms of lung screening, really, the short answer is no. There are no free screenings available that you could signpost people to. But there is no national plan for a national screening program for lung cancer, and the evidence for lung cancer screening has not really been fully established just yet. I mean, when you screen a population for lung cancer, there is a not insignificant level of incidental findings that need to be investigated. All those investigations come with risks to the patient, and the risk benefit of that really needs to be carefully analysed before you launch a screening program for lung cancer. So the short answer is that there isn't one, and there's no sign of one coming, and it's not even clear that there should be one just yet.
Okay, thank you. And we had another one there. The cough and lung cancer, is it usually chesty or dry or both? Is there a particular type of cough they should be looking out for?
No, it can be either. It can be either.
Okay.
Yeah.
One in here from Noel. So on average, how long do people who go on to be diagnosed with lung cancer have the unusual or persistent cough before the diagnosis?
It varies hugely, and it's very hard to look back and say, as I say, there was that article in the Lancet Oncology in 2013 saying that a third of people had seen their doctor 3 times before they got referred. Okay. There was a study done by, I think, a guy called Hamilton in the BMJ, and he looked back. They got people who had a diagnosis of lung cancer to look back, and a significant proportion of them would say they had symptoms for up to a year. Now, the problem is, though, when you have a diagnosis of lung cancer and you're told to look back, you suddenly start seeing things everywhere. So it's very hard to know how reliable that data is. But it does seem fairly clear in the literature, it's fairly consistent, that people can have symptoms for many months, not for many years, but for many months before they're diagnosed. So people are being missed.
Lovely, thank you, Una. Another one here.
Can I just add to that, Audrey, just a tiny bit?
Yeah, of course.
Just one comment is that, so you will have your patients who have maybe the smoker's cough or the more chronic cough, and you're looking for a change to that cough. But if someone has a new cough, I think a fairly good and well accepted benchmark is kind of 3 weeks. So if you have a new cough and it's persisting for more than 3 weeks, that's generally something that needs further investigation. Obviously, people with longer term coughs, it might be a change in the quality of that cough, and as Una has explained, they will know well if their cough is changing. But for someone with just a new onset cough, if it's some mild viral thing, really it shouldn't be lasting longer than 3 weeks. So if someone's coming in for repeated cough battles more than 3 weeks duration of a new cough, that needs further investigation.
Lovely, thanks, Heather. We have a little bit of time, so if I don't mind, I'll read out a couple more left, if that's okay. I have a question in from Elaine. So she said, what are the suggested reasons for the big increase in diagnosis in 2045? What are they basing those increases on?
So well, you can go ahead if you like, but part of it is demographic changes. We do have an aging population, we do have a growing population. So even if we are picking up cancers earlier, just by virtue of the demographic changes in the population, the aging population growth, we are going to see an increase in the number of lung cancers.
Lovely, thanks, Heather. And I've actually had 2 people ask this question. It's if a smoker stops smoking, so does the risk decline over time?
The risk that declines, but it doesn't go back down to as if you were a never smoker. There is a risk for an ex-smoker. And the risk varies depending on how many years you smoked and how many years you quit. So it's complicated enough, but it does not go back to as if you never smoked. But yes, it does decline.
Does decline. Okay, thank you, Una. We have, is anorexia or weight loss an early or a late symptom?
Oh, that's a good question. I don't know if it's early or late, and I don't know that I've ever read anywhere one way or the other whether it's early or late. I would guess I would say it's early in that it's probably one of the ones that are there when somebody's being picked up, but it may be late in the sense that the disease may have progressed. I mean, we know we're picking them all up. We know we're picking up 80% of them, 82% of them are being picked up late. So they're being picked up at a stage when we suddenly notice they've lost weight, and then we pick them up and it turns out they're at an advanced stage. But in terms of when we see them, it's one of the first things we see, if you understand. No, if I'm saying that really well.
Thanks, Una. I'll take one more question and then I'll hand over to yourself, Sarah, to finish off. Is that okay?
And I have another
Audrey,
question.
can I just ask, are we doing the poll?
Oh yeah, did you want me to do the polls? Now I can do them now, that's no problem.
Like, we can maybe take questions as well if we have time.
Yeah,
I think there's only a couple of questions on the poll.
No problem, I'll do them now. I wasn't too sure, let me have a look. So I'm going to just ask the first question. I'm going to launch that now. You guys let me know if you can see that. So
perfect. Okay.
Heather, if you want to read them out there, can you see it?
Yeah, so this is question 1. So patients value advice from their pharmacists. I think we've shown a lot of evidence to attest to that. So what are the reasons that you as a pharmacist might be reluctant to advise a patient to attend their GP? And you can select one or more of these. So time constraints, perhaps you might not be fully confident in your knowledge of lung cancer signs and symptoms. You may not want to frighten or worry your patients. You might have some other reason. And if you want to throw anything into the chat box, please feel free. And then, some of you might feel that you have no reason at all not to advise your patient to attend their GP, and that's something that you're confident doing and able to do.
That's the strongest answer coming through, Heather. Actually, we have 75% of people choosing that one.
That's great to see, because I suppose we were concerned, especially with the volume of visits that pharmacists get and things, time constraints might be a factor, like perhaps not wanting to frighten or worry patients, but it's just great to see that level of confidence and not having any reason not to advise a patient. That's very actually heartening to see that result.
Lovely. Thanks everyone for voting on that. There's nearly everyone has put in a vote on that.
Thank
so
you.
I'll end it and I'll just share the results with everyone so you can see what came in. Can you all see that? So yeah, there was a stronger 73% as I have no reasons not to advise.
That's great to see.
Lovely. So I'll stop that. I'll go on to question 2, Heather. Yeah.
Yeah, perfect. Thank you.
Lovely. Okay. There you are.
So on average, how often do you advise patients to attend their GP? And again, we do appreciate that you will all have different catchment areas. You'll all have different patient profiles. Some of you will have people coming in who are perhaps a more socioeconomically deprived catchment area that more fit the high risk profile for lung cancer. So, this will very much depend on it's just a Likert scale, very frequently, occasionally, rarely, very rarely, never. So, obviously, we understand ideally we get a bit more information behind what you choose there, but just to give us a flavour of how often you would advise a patient to attend their GP. Because as I say, pharmacists are so well placed, you're so well trusted, and a nudge from yourselves can really help on this pathway towards early detection of lung cancer.
The good news is there's no never and there's no very rarely. So
that's great.
Really good. I'll end that now and I'll share so you can see all the results there. So yeah, you can see very frequently, occasionally are up there in the top.
Great.
That's great. Lovely. Thank you for reminding me of them.
No problem.
That's grand. Will I hand over to you, Sarah? We're just coming up to 9 now.
Thank you very much. I just have one comment in from Laura Sam. Laura, I don't know if you want to speak to this as well, but just to mention some research that you're doing in terms of barriers, facilitators and strategies to recognise and refer high-risk individuals with lung cancer alarm symptoms, and that you're doing a qualitative and study with primary healthcare professionals. I don't know if you want to hop on and say anything.
Yeah, thank you very much, Sarah, and thank you to the IOP for a fantastic presentation from the NCCP. Just to say that I've had the honour of working a little bit with Dr. Kennedy on some research regarding lung cancer, and we've been fortunate enough to be working with the NCCP on this project about barriers and facilitators and strategies to recognise and refer high-risk individuals with lung cancer alarm symptoms. And I guess seeing how many people are on this teleconference this evening, this webinar, I would just like to put it out there that I would be delighted if anybody would be interested in taking part in this research. It would probably be a focus group at a time that's convenient to you. And, you know, we're not looking for many people. So even if a few of you thought, yes, this is something I'd really like to, you know, give my insights to, because I know that, you know, you've said here, you know, there is no reason why you wouldn't refer somebody on. And yet we know from what Dr. Kennedy has said that a lot of people are being diagnosed very late. And so it's to look at how can we overcome any barriers and how can we facilitate healthcare professionals in a patient-facing setting to refer on earlier. So if that's okay with the organisers, I would just put my email into the chat function. And if anybody would like to contact me, I would be more than delighted to hear from you.
Thank you very much, Laura. Perfect. Well, thank you. I want to say a huge thank you to our presenters this evening, and that's on behalf of everybody. We've had huge engagement with our last minute polls there, and huge engagement in the chat box with some excellent questions. So a very special thank you to our fantastic presenters, Heather, Patricia and Una. Thank you so much for sharing your insights and expertise with us tonight. We have covered a huge amount of information, but don't worry, the slides and a recording of the webinar will be shared with you all by the end of the week. I'm not going to let the opportunity go by without saying to have a think about how this will have an impact on your practice tomorrow, and that it might be a good opportunity for a CPD cycle. We're going to invite you to give some feedback on tonight's webinar. So I know Audrey is going to pop the link for the survey into the chat box, and we really look forward to receiving your feedback. And finally, I'm really delighted and excited to announce the details of our next webinar. We're really excited to have Professor Karina Butler, Chair of the National Immunisation Advisory Committee, and Brian Cleary, Chief Pharmacist at the Rotunda Hospital and fellow NIAC member, who will be giving us an update on COVID-19 vaccines. So looking at the vaccines that are currently available and those soon to be approved. So I'm sure you'll all understand that we wanted to deliver this next webinar in a timely manner. So please note the date. It's next Wednesday, the 27th of January. So we're not having our usual 2-week break. We're back next Wednesday with our COVID-19 vaccines webinar. So I know Audrey will be sending out the usual invitation and link to registration tomorrow. So keep an eye out on your inbox. But before we end tonight's webinar, a final thank you to all of our presenters, and thank you to each of you for joining. And I'm really looking forward to seeing you all next Wednesday. I'm not sure, I can't see the chat box at the moment, but if there's a couple of questions left, I'm sure we can get to those.
What I will do as well, if there's any burning questions, I can go through the chat tomorrow maybe and send them on to the NCCP. Sure. And if there's anything burning there that wasn't answered, but I will be sharing the presentation as well. But yeah, if there's anything there that we didn't cover tonight, you can send an email into info@iop.ie and I can forward it on to yourselves if that's okay.
Perfect.
Yes.
Lovely. Fine, that's perfect. Thank you. Perfect. Thanks very much.
That's
Thank
great.
you so
Thank you
much.
very much, everybody. Enjoy the rest of your evening.
Thanks, everyone. We'll see you next week.
Thank you.